stenosis. We already went over pulmonic stenosis. A lot of this will sound very, very similar to what we talked about pulmonic stenosis, in terms of like, hey, if it's mild, if it's just a little bit of stenosis, then that's not really a big deal. If it's a really large stenosis, then obviously that's a much bigger deal, right? So for whatever reason, there's a narrowing of the aortic valve, and the aortic valve itself might be a little weird. Has 2 valve leaflets rather than 3. They may even be partially fused, right? So because of these 2 things, it's having to work harder to push blood past some kind of narrowed valve opening. So obviously it can go anywhere from like mild and asymptomatic to severe, and with CHF, with if there's a significant stenosis, right? When it comes to peripheral pulses being weak and thready, this is true of any congenital heart condition which decreases systemic blood flow, right? So don't feel like you need to re-memorize that. Just think about these and think about it logically, right? All of these are decreasing systemic blood flow. That means that your pulses will probably be pretty weak and thready, right? Because there's not as much blood flow going to your body as usual. So that makes complete sense. Okay. So let's see, chest pain with exertion, activity intolerance, that also makes sense as well, because you're trying to do a lot of work and the blood isn't just getting to your body fast enough, right? And so you can easily become have a syncope episode, get really dizzy, and it can get bad pretty quick, right? So systolic blood pressure also may be higher in the right arm than the left, and that has to do with basically, so this is going to the right arm, right? Once you look at like anatomy book or any picture like that, you'll see that. And it has to do with the physics of the way that the blood is shooting up, and it's a lot easier to kind of just snake through here. It loses its momentum pretty quickly as it reaches this turn, and then it kind of just limps along into here to your left arm, right? So your right arm has a nice good pulse or a good blood pressure. Left arm like maybe a little weaker, right? So you don't need to know the specifics of that, but just wanted to, if you were curious about why is the right arm and left arm different, it has to do with the physics of just fluid moving through and just taking that turn. But anyway, so you'll hear this systolic heart murmur and a thrill as it goes through. So that's actually very similar to the pulmonic stenosis as well. Splitting of S2, also very similar to pulmonic stenosis, right? You're creating an uneven situation between the left ventricle and the right ventricle, so you get that splitting. Okay, let's see. I already talked about at length. Chest X-ray and EKG are both for size, right? So it may be a normal sized heart. It may show like left ventricular hypertrophy if it's severe, right? Echo is going to tell us all the little stuff like the valve leaflets, the pressure gradients, the size of things, all that kind of detailed stuff. Because we have this chest pain with exertion or maybe syncope with exertion, we may want to do an exercise test to make sure that that the level of exercise, that whatever they're doing, is safe. Obviously, we'll only give prostaglandin E1 if it's serious, right? Prostaglandin is not a benign drug. It's pretty dangerous to give, actually, as far as drugs go. I mean, of course, all things considered, it's a lot more dangerous to withhold prostaglandin from kids who need it, but it is one of the more dangerous drugs when you think about the different drugs that you give. There's a lot of really bad side effects, so we don't want to give that. But obviously, in this situation right here, right, if we're not getting blood to the system because this is just totally blocked or like super blocked, then you can actually cheat a little bit by having blood just kind of snake along right here from the pulmonary artery, right? Usually it goes the other direction from the aorta down to the pulmonary artery, but because the pressures are so low in the aorta, because it's not getting this blood from the left ventricle, it'll actually go the other way. It'll go from the pulmonary artery into the systemic circulation. Okay, so that's why we want to give the PGE1. You might want to give like dopamine, diuretics, just our usual CHF meds, balloon dilation, and surgical treatment, pretty much exactly, and surgical valvotomy, right? So the interventions are pretty much identical to those of pulmonic stenosis. So you learn one and then you learn both, right? Just either to the pulmonary artery or to the aorta. And even the valve replacement, the possible valve replacement. So we saw that in the pulmonic valve for pulmonal stenosis. Now we're seeing it for aortic stenosis as well. They may need a aortic valve replacement. So when it comes to prognosis, so I mean, you can even have sudden death during vigorous exercise, and that's why these exercise tests are super valuable. It's very important to educate parents about the dangers of vigorous exercise and what to look out for. So you can have progression of the disease. So this is kind of a different part than the pulmonary stenosis. Pulmonary stenosis generally stays pretty stable, but for aortic stenosis, you can have this valve calcification, and then you can progress and get worse and worse.